A very good evening to you, and thank you so much for joining us for this edition of Spectrum, live on Radio 1 FM 90. Radio 1 is broadcasting from the central building here in the heart of our city, Kampala, along the Stool Street. We're also coming to you live on our website, which is www.radio1fm90.com. On that website, there's an icon with the word Listen Live. What you do, you click on that icon, and you'll be able to listen to us from anywhere across this globe. Radio 1 is also live on the different radio listening apps: TuneIn, Afromobile, Your TV channel, Radio Garden, and Streamer Freak. Those can be obtained from the Google Store of your smartphone. You download any of those, you look for Radio 1 FM 90, and you will be in business. The other option is DSTV. Our audio channel there is 897, so if you have a DSTV connection, move your remote, look for audio channel 897, and you'll be able to listen to us loud and clear. Today we'll be looking at the state of health sector financing in Uganda. Well, we know health sector is one of those critical areas that everyone looks at when analyzing the national budget. There are a few facts about how financing has actually been occurring in Uganda. We know the health sector is largely dependent on donor support. We know also that the health sector has not yet met the threshold which was set under the Abuja Declaration, which is 15% of the total national budget. We know that most Ugandans spend out of their pockets to meet their healthcare needs. That's according to WHO. Now, we know most serious cases, especially of government officials, are normally referred abroad. That's on record. We have seen a number of cases. People were actually referred abroad, and it has become a topical issue. We know that Uganda has well-trained and skilled healthcare personnel, but there are those who have left the country, and they say it's largely because of poor working environment. But we also know that there's a huge staffing gap when you look at the job slots or the gaps that are yet to be filled as far as healthcare and human resource is concerned. President Yoweri Museveni 2 years ago had directed that every sub-county should have a doctor. And not so long ago, there was the lifting of a ban on recruitment of health workers after 5 years. And there are reports that actually there are some impediments already in that particular regard. Well, yesterday, the Uganda Medical Association issued a press release about some of the burning issues in the health sector, especially on the financing side, including they are concerned about the recent decision to actually reallocate some money that had been set aside for revamping of the national ambulance system, and also construction of ICU at one of the main hospitals in this country. So today we'll be looking at what's happening in the health sector in terms of financing, the priorities therein, and the unfunded priorities that actually need to be paid close attention to. My guest this evening, Dr. WIlberforce Kabweru. He is the chairperson of the Ethics and Professionalism Committee at the Uganda Medical Association, but he's also a medical doctor working with Mulago National Referral Hospital. Good evening, and thank you very much for joining us, Doctor.
Thank you very much, listeners of Radio 1. As already introduced, my name is Dr. Kabweru WIlberforce, and I'm a senior consultant surgeon working in Mulago National Referral Hospital, where I've just left now to come and actually discuss the health financing in Uganda. And also I chair the Ethics and Professionalism Committee in Uganda Medical Association. Now I'm standing in for the president, who is on official duties elsewhere. So if I just take a smaller step back, that actually the health financing system has taken different strides. And if you remember that during 1980, I think after that difficult 10 years of Idi Amin, there were a number of changes that were actually affected. You remember during 1970s, there were so many things that had taken place, and it was difficult to get most of the services in the country because of the changes, political changes and instability that was happening in the country. So that means when it came to 1980, when other governments came into place, and then obviously 86 when the NRM came into power, they started revamping some health reforms, and they were calling different partnerships, partners actually to come and partner with the health sector so that they improve health service delivery. We know that actually you can't hold alone, and you can't make your own cake and eat it alone. Health sector is quite very wide, and actually it's very expensive a venture. And we remember that even during 1990, we also had some other reforms until 2001 when the cost sharing was abolished. That is in quotes, the official one. So we went to what we think is free services. But health services are never free. Somebody is paying. But who is paying? I usually go back and say, you who are paying for your health services, either directly or indirectly. What do I mean? If we look at this current situation, you realize that actually 60 to 80% of Ugandans pay for their services
out of pocket.
And that is a very big factor. It depends on a number of things. It keeps shifting, but within that range. So the rest is covered by government. But still, who pays for government? It is not government. It is you. Who defines the government? It is you, the taxpayer. So you are paying directly or indirectly for your services. So all the things, when you put them together, it means at the end of the day, you have to have a budget to your health. If you don't have a budget, then at the end of the day, you'll face the consequences. Right. So when you go to Mulago, for instance, and there are so many free services, but you reach somewhere, and then some of these free services cannot suffice for the entire population. And you see it is the only national referral hospital for now the 49.5 million people. So how do you think it can work out? It is 1,500 beds in patients, and we say number of outpatients. But the challenge is that the budget, the health budget, keeps dropping every year. So you cannot maintain the health services.
All right.
That state.
All right. Let me introduce our second guest, Dr. Ekwaro Obuku, physician, researcher, and health policy expert who served in the past as the president of the Uganda Medical Association. Good evening, Dr. Ekwaro. Thank you very much for joining us on this edition of Spectra.
Good evening, listeners, and thank you very much, Mr. Lukwago, for inviting me once again. I had heard on NBS people saying that Obuku is lost, is somewhere eating, and I'm very happy to come back to share with you what I'm eating.
What have you been eating,
where I'm
Dr.
eating
Obuku?
from. I've been eating cassava, posho, black beans, what we call modugabu, in a district called Oyam. So specifically Oyam South, the constituency where I am going to run.
Hey, you're going back.
So I've been with the people, the Otedero. I'm the general of the Otedero.
Absconding from duty.
I'm not absconding from duty. I'm an independent consultant. Yes.
All right.
Yes.
Thank you very much for joining us. You found us with Dr. Kabweru here, already reflecting on the realities of our health sector when you look at the side of financing. What's your take? What's your quick recollection of the situation where we are? Are we doing enough, or certain things need to change?
You know, I learned that you must start by saying good things about the government. Let me try to find good things, because it's very difficult sometimes, especially when the same government has been around for some time. So, over the 40 years, life expectancy at birth has increased from less than, I believe, 45 years to now over 65 years, which is a very big marker of general improvement on the quality of life at population level. Okay? The population itself, we have recently had a census, has perhaps come from less than, was it 15 million or 20 million at about to 1986? It has tripled to over 45 million. In terms of ecology, okay? That shows you that the environment is favorable for the organism, in this case human beings, to thrive as a general outlook generally. And from the political perspective, compared to the past, where we had all these, political changes frequently, and wars and so on, we've had a general level of stability, of course, in the south mostly, then later in the north. And perhaps that stability, despite our challenges of democracy, our challenges of human rights, our challenges of actualizing the 10-point program at the grassroots, and all these other models we've, PDM and so on, we have thought would take Uganda to the next leap, despite their challenges. That is the outlook. Now, the health sector, I would like to inform the public that the money has increased from 3% in 1986. I think it almost touched 10% about 10 years ago, and now it is declining in proportion. But in absolute amounts, it increases, in absolute amounts. There are other good areas I'd like to point out. I have visited nearly all the health center 3s in my constituency there, Yam South, and I'd like to report that I found that the body mass index, or the MOAC, or the skin thickness, if some health workers are hearing, of frontline health had improved, and their outlook. They don't look emaciated. They actually look well. General, what do you call it? General what?
General condition.
There's something we normally say, general good condition of a patient, and this time of the workers, they have the energy to work. The limitation, when I tasked some of them, because I went down to the people and said, what are the challenges in the health facility? They say, these health workers are not there. So I asked the health workers, what is the challenge? They said, half of the time, there is nothing to use. So, Obuku, yes, you guys fought for the salaries.
Supplies.
But can you also fight for the medicines? That is a more complex problem. Salary is targeted to it. Now, Dr. Kabweru here is my senior consultant. His salary comes, his number, he has a unique number, I believe, isn't it? You have a unique number, employment number, isn't it?
Yes.
And your salary is known, it can be traced from the consolidated fund and so on, or Ministry of Public, whatever. But now with medicine, amounts are allocated. Prices, there are market fluctuations. There are procurement delays all over. But also there could be efficiency gains, what we call corruption along the system. The procurement, supply, delivery, and prescription pathway.
The chain.
You get? So that is the challenge now for medicines. With the blood, we solved that problem. In that struggle 8 years ago, okay? When we engaged the state as the medical association and other members of the fraternity, the amount of money given to the blood transfusion services doubled. In fact, it reached a point where they could not spend, and I think now they are spending money in the capital investments, expanding the regions. You're getting me? Now, when you're going to capital investments, expanding into other regions, construction works, which are very attractive to government accounting officers, then there also you cannot trace the money very well. And that is why there can be apparent deficiencies. You get what I mean? Because what is the price of cement? It is known. But in a procurement where money is going to be paid later, it can double, it can triple. A very good example is what we are now calling the Luboa International Underground Hospital, which is said to have consumed over $100 million. And it is still going, I don't know how many levels. Maybe it's at 7th level underground.
No, the actual constructions.
So you are not seeing it. You remember the story of the Valley Dams, where the vice president was saying, they are there, but you are not seeing it because you don't know how it looks. So for us who know hospitals, we are saying this one is a unique one. The first one of its kind, it's underground. But the issues I would like to discuss here today concern the peripheral health facilities. I have here a follow-up request for support toward strategic challenges affecting the health service delivery in Oyam district, as an example of the 130 something. I hear the 146, but me, I remember my brain closed at 135. But I hear they are 140. I've seen writings where they are 146.
Those are health center 3s?
No, districts.
All right.
So I want a case study of Oyam district, which is located in northern Uganda, specifically Lango sub-region. And I'd like to read to you this letter, which is a public document anyway, written to the permanent secretary, highlighting the challenges. For example, right now, there is mixed communication from government. Thank you very much. You increase salaries. Government has done very well and increased the number of health center 3s in my sub-county, in my district. They have nearly converted all the health center 2s into health center 3s, which is something good. They had only 3 public health center 3s in 2018. Now, it has 10. It is a plus. We must praise government. You know, sometimes it's difficult to find good things. It is easier to find the difficult one. But what are the challenges? The staffing is a problem.
I was about
Now,
to ask you in
out of these 10, the wage bill for 4 is there. But I've just seen today a letter freezing what? Recruitment. So there seems to be lack of coordination. Because if you reach the cow or the district health team or the administration of Oyam district, they are saying the money is there for health facilities. What are we going to do with this money? When there is this letter banning us, if they recruit, they will face the music. Isn't it, Auditor General and so on? So I think it is important that when resolutions are made from government, they should be granular. And they should be granular. You know what I mean by granular? Don't just issue a blanket one. Say, okay, get who are the ones with the wage bill, so and so. So Oyam district might not spend its wage bill for 4 health facilities, and I think their names are actually here indicated in this letter. Okay.
All right.
Now, the other thing that is important is the delivery cycle of medicines, because I went and saw over 400-500 patients in a space of 1.5 months. Going to this health facility and trying to attend to them. The workers on the ground are saying that the current delivery mechanism is unpredictable.
Erratic.
And yes, and there is need to go back to the 2 monthly cycles, which are predictable and spread out evenly. It helps them.
All right.
Now, the third aspect, let me finish this. The third aspect is the changing disease burden. I was very surprised, this is my senior here in clinical practice, Dr. Kabweru, that we were finding blood pressures of over 200, over 100. A normal one is 120 over 80. So we're finding nearly double, and the person did not know. In the rural areas where you don't have well-fed people like our host here, who has given us good cake and coffee, I think that's what you feed on daily, or your wife is a very good cook like mine. Okay? There in the village, at times the money is limited. We can talk about don't fry foods. No, they don't have cooking. They are like in my village. We call it lelo dek.
But they have
you get what do we call this?
Sim.
You get simsim and mix it with the beans, and it is delicious and healthy. But I think the challenge could be things like salt. Because normally their food with salt is really, I don't know, is salt a risk factor? I think it's a risk factor.
All right.
Last time I checked.
Now, let's look at the situation. First of all, a report card for last financial year, some of the key issues that the government really achieved last financial year, depending on based on the report which was presented by Matia Kasaija as he made the budget speech. One of the things they achieved last financial year, 3 regional blood banks in Arua, Soroti, and Hoima were completed. Government provided 116 new ambulances to 100 constituencies and another 10 ambulances for regional referral hospitals for the command center at Naguru, among others. And they also managed to elevate 261 health center to health center 3s. I think those are some of the health centers you were talking about. And they said more were actually going to be worked on. And this financial year, additional financing for essential medicines, 100 billion has been provided. And also they are looking at digitalization of the national health care system as one of the key issues they are going to be looking at. Well, let me come to you, Dr. Kabweru. Let's look at the allocation. This financial year, 2.9 trillion shilling goes to the health sector. We know there are priorities there, but there are also what you people call unfunded priorities. Is this sufficient, the 2.9 trillion, looking at your position as the Uganda Medical Association?
First of all, let me just start with a small note that, for instance, if you look at the medicines requirement for only Mulago Hospital, they desired by the Mulago National Referral Hospital, it would need, in just one financial year, it would need 130 billion to run.
For medicines?
Medicine alone.
Medicines.
Yes. And that means that if you give, they have given us how much? 200 billion?
They have given you 100 billion for essential medicines.
That means
in
that
addition
is,
to the budget
that
NMS has
that is
already.
only adequate for Mulago National Referral. Not even the specialized hospital. Without transplant, without water and other things, but just for the National Referral Hospital. So what am I saying? That we thank government that it has made that addition, but that is a drop in the sea, because if you have traveled around this country, it is very, very difficult to actually ascertain that actually most of the people get the required drugs. For instance, you may see a patient and he needs only 3 types of drugs. He needs Panadol, Coartem, and probably Amoxicillin. But at the end of the day, the patients you have seen as coming from home to the hospital and back, outpatient, you may realize that they may not go back with all those 3 drugs. They may go with some little Panadol, Amoxicillin, and then some Coartem, or a complete dose of Coartem, because that is a donated drug. But what we have bought may not be adequate. So we actually implore government to increase that budget of drugs, because the requirements for the entire country may be very huge. If Mulago alone needs 130 billion, and you're saying you have increased by 100 billion, that is now for only Mulago alone. So the rest, what do? We have around 18 regional referral hospitals, and so many general hospitals, so many center 4s, and 3s and 2s, and CDD, the community drug distributors who reach the village person, isn't it? Or the household. So basically there is work.
All right.
As they always say. And then I'm coming to the other point about staffing. My dear, this country is under severe understaffing, and every time you improve an infrastructure, it goes along with a structural system for the staffing. So at the end of the day, if a unit was a health center 2, which had a lower staffing norm, and then you increased it to a health center 3, it means it has to move along with the human resource. Because if with the human resource, you would deliver nothing.
So now we have invested into infrastructure.
So we should also
invest sort of
in human resource.
Turned health center 2s into health center 3s.
Yes.
Now you people are saying there is a letter that has come out today
to freeze
recruitment. So what is going to happen to the equipment? To how will those health centers provide services to the people?
Probably I would say it is a simple guess. What happens when you go to Nakasera and buy a lot of perishables and you put them there? Because this equipment and whatever undergo wear and tear. So if you keep them there and they are accumulating dust and whatever, they break down, my dear. There's nothing scientific.
May I supplement on staffing?
One last issue before I actually come to you to supplement on staffing. Dr. Kabweru, there's an ongoing debate on where actually we should be investing when it comes to healthcare. The people are saying we should be investing more in primary health care. We have village health teams, provide them more funding so that they can move around the country, sensitize people to prevent diseases, as opposed to running to hospitals when they have actually been infected. And it's clear the primary health care budget is not well provided for. So where do you think, in your experience, where should we be putting the money? Probably to address the situation that we are in.
Actually, I should even thank the government, because it has tried in terms of prevention. What does prevention mean? Before a disease comes into your body, isn't it? And you know there is the immunization. In the national immunization, Uganda National Expanded Program for Immunization. And it has done tremendous work, and it has been increasing on the number of vaccines to avert the diseases from coming into the children. But also there has been a lot of health education for preventive measures. But the truth is, we are in the tropics. So in the tropics, the diseases actually are diverse. And that means that actually sometimes you need to improve on our diagnostics to make sure that we have an accurate diagnosis, and also be able to manage that particular condition that we have diagnosed. So I think it shouldn't be a one-prong it should be a multi-pronged approach. Yes. Others, if you just say we are preventing, you end the topics, what happens to the others who have contracted this? You need to make sure you effectively manage them as early as possible to prevent the complications. So it is our onus to make sure that we use a multi-pronged approach and manage that situation.
Well, Spectrum on Radio 1 FM 90. Let's go for a break now. When we return, Dr. Obuku is burning to contribute on the issue of staffing. How do we address that issue? We are actually told there are so many doctors there, but the staffing gaps in the Ministry of Health remain very high. I was looking at some of the statistics there, and we are being told the staffing level is now at about 74%. Is it true? Well, let's go for a break. When we return, we'll begin from that point and then look at the other aspects as we continue reflecting on health sector financing in Uganda. Stay tuned to Radio 1 FM 90. Well, thank you so much for staying with us on Spectrum, live on Radio 1 FM 90. Our topic of discussion today, we are looking at the state of health sector financing in Uganda. It has implications on health service delivery in this country. My guest, Dr. WIlberforce Kabweru, chairperson of the Ethics and Professionalism Committee at the Uganda Medical Association, is a senior consultant surgeon at the National Referral Hospital Mulago. Dr. Ekwaro Obuku, a physician, researcher, and health policy expert who is in private practice as a consultant. But you might have heard there he has some political aspirations, which I think we'll discuss when the time comes. Dr. Obuku, you wanted to comment on the issue of staffing.
Foremost is to clarify here that the government actually has upgraded 10 health center tools to 3 in Oyam district and constructed 3 new ones. You know, I was very surprised when I toured these myself, and I met a very good facility called Ajaga. Very new, but they said they had not included it in the what? In the receiving drugs, but they had given it money. Then there was a health facility near Karuma. You know, Karuma was supposed to be the first city. You remember, deliberately around Karuma Dam and all those energy projects. There's a facility constructed as a CSR, not the CSR of Parliament, but the true one, by Sinohydro. The corporate social responsibility of Sinohydro, the health center they call the Chuni Health Center, very good. The staffing thing you see is very good. You get. So I just wanted to recognize those two contributions by government, but those issues are sustained, like staffing. But how do we interpret staffing? 2 ways. There is the quantity and the quality, or what we call productivity. I have a challenge with health workers not being in the facilities and creating apparent absenteeism. Or these numbers we talk about, the doctor to patient ratio. These are just estimates by experts to say that if you have this number, it is good. It's like the GDP. It is a figure to just compare with others. But in reality, you must assess yourself.
Your pocket.
You are getting me? If the doctor is available in the facility, if his home is just near there, okay? And if the drugs are available, and the doctor in the health center actually has a what? Has an anesthetic officer. And there is a blood thing somewhere.
Blood supply.
You get? These ratios don't mean much. You get? There should be a distribution, what they call a skills mix. So the Ministry of Health should carry out, and I heard they were doing it, but I've never seen that study. They call it a market analysis, productivity analysis. It does not permeate to the ordinary person. Doctors and other frontline health workers are saying if there are no medicines in facilities, we find ourselves in the private facility, now private facilities, where we can offer these services. And once that is permitted, then there is communication of medicine. Medicine moves from here to there. It becomes a big challenge. Let me provide solutions. It's not enough to complain.
All right.
What are the solutions based on research evidence which has worked?
Yes, well.
1, efficiency. How do you get efficiency? Diminish the issue of a monopoly. Right now, medicines is a monopoly. National Medical Stores has a monopoly. There is always ping pong between the district and the National Medical Store. National Medical Store can say we have delivered 100 boxes. Then you go to the district, they say all of them are empty. Now. We don't have antibiotics, we don't have antibiotics. You get what I mean? Or they say half of them are condoms. So when a parliamentarian goes there to say we are doing oversight, they are shown boxes, they don't know what's in.
NMS says they are operating an electronic system which is supposed to address some of those. You get the actual thing you ordered for.
You see, let me tell you a secret. At the end of the day, you must listen to the end user. NMS is a corporate organization with much respect, but it must continue to attend to that challenge. NMS has been crying no money. They have given them another $30 million. And actually, I've been comparing notes with Dr. Kamavale, who is the CEO, and saying, how is it this year? He said, this year, facilities are going to be choked. They may fail to use the medicine. And I said, this is wonderful news from you, the CEO. Let us hope the facilities will actually pull the medicines. There will be fuel to make sure the last mile delivery happens. So that's one, efficiency gains. By the way, you know what happened in Tanzania? Once they changed the president, he reorganized the Tanzania Ports Authority, and all of a sudden Tanzania was collecting sufficient revenue to even become a what? A middle income country. He strengthened the governance of the mining sector. These things Mr. Museveni is doing, strengthening governance of coffee, strengthening governance of what? Strengthening governance of this. It can improve efficiency, you know, so that there is a value for the shilling. The second thing is government must rethink its health financing strategy.
Public.
You know, in reality, the mantra of free health care is good, and it must remain. Why? If you engage the president of the country, who is a resource anyway? He has been, he's the only constant factor K. 1986 to 2026 K is Museveni Kaguta. Now, he's a brain. He tells you that what will happen to my people, the voters. And if you've been on the ground, Dr. Kabweru, you'll bear me witness. I've been there the past 1.5 months. After so many years, you find that the people on the ground are not in the monetary economy. So you must have a two-tier system, okay, in purchasing health care. How? The Kabwerus here who are senior consultants with the money, they can go to case clinic, they can buy. That is why we give them good money anyway. This man is now on 13-point-something million from 3 million.
That's a gross.
That is gross, but it's okay. You can now get a loan times 10, 130 million. Those days it was 30. You are getting me? And it's public. I'm not announcing him. He's not in the private sector, but he's at the highest level, senior consultant. The lowest level moved from 900,000 to what? To 5.4. You are getting me? So the guy who could get 9 million now can get 54 million on a loan. So there are those other advantages. What am I saying? These Kabwerus can buy their health care. We can charge them through insurance, which is a prepayment scheme.
All right.
Okay? Or even out of pocket for some services which are complicated. You're a cardiothoracic surgeon. He's a cardiothoracic surgeon. He can open your chest, check the lung, close it, and not this thing of gravity, but the real one.
All right.
Now, wait a minute. Now, the guy in my village, there is a gentleman who is called Mr. Edeng George. Edeng George comes from Adigo. Adigo is found in Loro satellite city, which is my sub-county. Distance. Okay? So what I'm just trying to say, 300 kilometers from here. What I'm trying to say, that guy, Edeng George, he goes to Adigo Health Center too. He needs an insurance mechanism based on the national identification system and the voter system to identify people and characterize them through the census. They say that they counted everybody. Right. So they know where you are and so on. That system, information-based system, to characterize them as someone who will need the support of government funding. So Kabweru pays 1 million shillings. We keep 300,000 for him and his family. The other 700 goes back. Which village do you come from?
Bujiri.
Bujiri. Which village exactly?
That's a Budidi.
Budidi village in Bujiri. And it goes there to take care of those who are less privileged. Right. Because those people, they pay the taxes through selling sugar for Kabweru to become a senior consultant through a government scholarship.
And then
that is the spirit of solidarity that must permeate.
All right.
People in the parliament there, okay? And this is the tragedy. Parliamentarians, big people in the government, all these parastatals, the revenue authority which collects money, the finance, all these big people, they have schemes based on taxpayers' money to pay for them private health insurance. You know what I mean? So that is the contradiction that should be addressed as a general outlook. And I hope Dr. Govi is listening, because he talked about economics that works. One thing is to redistribute that opportunity
of insurance
to the poor,
and that's what I wanted to come to.
Through equalization mechanisms.
All right.
National health insurance scheme.
All right. And
we
that's why
have
I'm
talked
coming.
about it for 30 years.
And I wanted to ask Dr. Kabweru,
And it has
even
not been
you,
started.
would the national health insurance help in this situation where we are?
Actually, I could go back and say there are mainly three ways of procuring health services. You either pay directly out of your pocket, or you co-share, whereby you pay something and the government pays something, and then the other is insurance. Now insurance has already alluded to somebody is paying because there are deductions off either your salary or something, but it would help. It will go along to help a lot in service delivery. Why? If put to the appropriate, I think, appropriate system. What do I mean? If I pay my, they were suggesting 4%. So if I pay my 4% either annually or monthly, then it should transform. Out of the 4%, I can say 1% remains with me, 2% goes somewhere, and then another 1% goes somewhere, so that at the end we pull together. When you pull together, even though I've paid for insurance every month, I may not utilize that money, but somebody else could actually find it of very great use, and it actually it boosts someone getting all the services. And I want to allude today that actually sometimes when you look at money increasing, but there's also the other factor that keeps increasing, which is the inflation. Every time our Ugandan shilling last year was not as strong as
depreciated a bit.
Yeah. We should appreciate. And that means that when there's some depreciation of some sort, what you could afford the other time, you are less able to afford now. So that means that we should actually put our emphasis on making sure that we chase or we pull or pluck wherever we can get it from, and we put health insurance for everybody. The president has always been very clear who will pay for my voters. There's especially the people who are not working. But I know if we collect money and people not give it away as awards, but it should go to the actual thing so that it procures what we want, then I think at the end of the day, it may be the bullet. It may be 50% to solve
some of the challenges we have.
But also we want to appreciate that as government is improving on a lot of critical care services, constructing intensive care units in the country, we should not forget one thing, that this is labor intensive and a lot of resource.
And you need skilled labor.
And very skilled. The intensives and people who are using the ICUs, they should be at top notch. The country has, because one of my research that I did recently was about the intensives. They are doing the old things around in these ICUs around Kampala. So it is the onus of the government that is the good thing is constructing. So we call upon it not to divert that money and let it go and complete that ICU in
Masaka.
Yes. Well, but because we keep getting those patients, and the moment you need ICU, you need.
Because of the president's intervention the other day. That's a finished agenda, not so.
It should be retaken back and constructed.
We must, you're a surgeon.
Yes.
You must step back and make an analysis. Our budget the previous year was 40-something trillion. It came to 52 trillion. Then it went to 72 trillion. I have been asking colleagues at the Ministry of Finance, can you send me the public document of this breakdown? Because the budget speech was here and there. You couldn't have one table which is clear. Then, which communicates well to the common man. It can communicate to the accountants and auditors.
And the parliament.
But it could not communicate to the common man. The simple thing, you say health is this, is a pie chart, and simple. I
You know,
requested.
we operate a cash budget, not so.
No, we needed to just see what is being planned. So my question to the Minister of Finance, who is also my OB, Honorable Kasaija, from SMAC, I'm the publicist
Of your association.
and then the organizing secretary and the publicist. The thing jumping from 52 trillion, then to 58, I said, that's quite a bit. Then now to 72. So you're increasing the budget by about 30%, 40%. I was wondering, what is the outlook? Is there a windfall from oil? Where are we going to get this money? And therefore, I said, okay, if that is the case, I said, let me look at the budget of the health sector. Has it also increased by 30% to reflect investment in what Mr. Museveni himself, during the lockdown, it made us sober. Himself, he said, keep quiet in the bush. Then you start hearing things. So he started seeing something called the real economy. And one of them he talked about was health security, food security, education security. We must do something. In a way, you would have wanted to pray for lockdown. Because lockdown seemed to have sobered up everybody, including himself. He told me, Obuku, you have become sober because of COVID. I think he also became sober and identified health as an investment. Not a consumption. And therefore, I'm not very excited by this budget, because it's not clear where the money is going to come from to increase by that proportion. Secondly, there is the issue of information guiding investment. I'm very pleased that government is investing in information systems for health. You go for passport office, for a passport at passport office. Go to the URSB. This lady, what is her name? The ED. Kind of wish she has made that place wonderful. Because me, I had children when the other, you remember they extended the birth certificate to those days of waiting and someone else signed manual. You go to the driver's license. You cannot
Everything
believe,
is digital.
No, you cannot believe you are getting the things there, and then you have paid the money on what is it? Mobile.
And one of the key priorities. Let me just read it for you. Yes. One of the key priorities of this financial year is digitalization of the national health system to facilitate service delivery and tracking of medical supplies and health workers' performance.
No, they should say and prepare for.
And I've seen
the
already,
national,
and I've already seen the launch of digital systems in hospitals to track absenteism.
No.
And
they are focusing on the wrong end of it. Don't invest in absenteeism.
This is what you've been calling for.
Invest in
the working environment.
Invest in information to help you to plan in terms of financing. You know that thing of absenteeism, okay? They tried this thing of clocking in.
Well,
hold on. And
they are paying people who are not on duty.
So what should happen is to enforce through the managers. Duty rotas are put there. If you know, the nurses are very good at ticking. You can even tick, have I come, have I not come? And it can be linked to what? To your paycheck. And the Kabwerus of this world should not be paid salaries. The Kabwerus of this world should be paid consultancy fees. He comes, if he wants to come once a week, which is typical of these seniors.
So
they are so big.
They should not be on a permanent payroll.
They are like generals. You know, generals stay behind.
They should have performance contracts.
And they keep making phone calls. Yes, performance-based contracts would help, because also he's being denied opportunities in the private sector
where he could be.
Because when he's seen there as a senior, I say, but now you are supposed to be here. So you can have a win-win situation where Kabweru skills are needed in the private sector and the public sector. We say, okay, you are giving us 2 days a week. Is that okay? He knows Monday, Tuesday is here.
All right.
Wednesday, Thursday is there. Then Fridays in his farm in Ujiri.
All right.
You see what I mean?
All right.
But currently we are using the colonial approach. And the colonial people have left this system, but Africans love it so much. It's like Christianity. Now the church is crazy. Everywhere I'm going to the village, every corner is a church. I ask them, why don't we fundraise for a school? Say, you talk slowly. The church is powerful, which is okay. We love the church, but we are loving it more than those who brought it.
All right,
same as the colonial,
all right,
public service
Dr.
system
Obuku,
is inefficient.
Let's hear from
and if you read the 10-point program, Museveni's book, What Are Africa's Problems? among them was an inefficient public service, but he has kept it.
All right. Let's hear from the people out there. We have a comment coming in from Todi David Adoki, who says, what happened to the president's proposal to formally integrate the village health team into the payroll, given the vital role they play in healthcare service delivery? Okelo Patrick Bonyo from Busega. The gentlemen in the studio are having a good discussion. Why can't we introduce health insurance for the Wananchi, where maybe they pay 20K or 30K a month and be able to treat common illnesses, because the current policy is way above the ordinary citizen. Medical is a major setback for many ordinary families. By and large, public health services still stand among the rest, with the exception of Nakasero and the likes of this world. How can we improve our healthcare services in Uganda? We have another comment coming in from Benon Fred Twinamasco. I'm wondering if NMS has a collaborative relationship with other agencies to use predictive distribution of drugs beyond the requisitions made by hospitals and health centers. We know cholera and malaria shows up during rainy season, so some drugs corresponding to such outbreaks will be prepared. Thank you for the show. We have another comment. Healthcare. Uganda is a signatory to the Abuja Declaration, pledging to commit 15% of its budget to healthcare, and this is one of the indicators tracked by the World Health Organization. Unfortunately, less than 7% is committed to health, and no wonder our health system in itself is in the ICU. Well, those are some of the comments that are coming in. Let's wrap it up and respond to some of these issues. Dr. Kabweru, I'll begin with you.
Thank you very much. I just want to start by saying that the health services are one of the most expensive good, and it should be a public good. But then if it is a public good, we should also make sure that actually we put a small budget on it. I'm very happy with the person who says, let people pay what they can afford. Even that village person, let him pay or her pay 20,000. I think that is the way to go. It was here earlier on, and I think if we
that's what cost sharing.
Because inevitably, if you're not affording the insurance, then you have to cost share. There's
but people are already paying taxes.
That is true. But the truth is, everybody pays taxes, but the value for the taxes they pay, they are not feeling it. And that's what we are saying. We should feel it.
Perhaps, thank you, Dr. Kabweru.
Yes, very quickly.
You know, the system should be rethought. It's not only money,
yes,
but there should be citizen participation. Citizen participation is the direct governance. Right now, if I'm a director of a hospital, I have no obligation to the community.
The community where I am.
They may never even see me. I'm in a Prado, in, out. But if we have a system where they can spend at source, you are getting me? They can spend at source, then you distribute the risk. If you centralize in a national health insurance scheme, we did a research as our research team at the Africa Center for Systematic Reviews and Knowledge Translation here at Mackay University. When I was doing my PhD, we showed that among the 10 most important concerns were one, the perception of corruption, if money is put in a pool. And I can tell you the appetite at this time, after the CSR in the parliament, and in fact, I was looking at the wage bill here, needed, 1.6 billion. Is nearly the one of the 4 commissioners who are going to swallow 1.7 billion. You are getting me? So they have not represented.
Are there no corruption tendencies in the Ministry of Health sector?
No, what we are saying, distribute the risk. Now it has been concentrated through taxes. How you can do it is distribute it. The Kabweru's patients are paying money indirectly, even if they don't give Kabweru money. Kabweru says, okay, we need 10 items. Government has IV fluids and blood and a few sutures. Go and buy this expensive antibiotic. Go and buy these materials. Go and buy these materials. Okay? So out of the 10 million needed for surgery, Kabweru's government has paid for 2 million, and the 8 the patient must pay. So instead of doing that de novo, whereby if Kabweru is found operating, he can be tasked. If that is a relative of someone big, they can call, why are you operating this? Are there no things? You are getting me? Let's formalize that system. Instead of paying 8 million, we pay this 4%, then you're entitled to this. But also citizens must participate. Because I'm paying, I can demand. Where is my file? But now, because you are paying to this person called Central Government and the Bank of Uganda and URA, which is an amorphous structure of nobody is in charge, really. You get me?
We have a government in charge.
No, in terms of the perception of who is in charge, whom can you pin in reality?
Yeah,
but there you have. Where is it? That citizen participation is very, very important, and it's the advantage of what? Of health insurance. They are experts. They have done studies. I don't need to talk. My teacher, they have mechanisms. The most important thing we must learn is you must start. Rwanda started, we have left her. People can say so many bad things about, the system is like this, it's not so, they are poor, but they have started. And let me give you an example of Thailand. It took 30 years of the insurance scheme to mature. It also matures, and then they start bringing in things like dialysis. In Thailand, it took 30 years, 1980. Then in the election year, they said we are going to add dialysis. So instead of buying all these big guzzlers in the government, you say, no, let's buy dialysis machines, guys, no new vehicles. The roto reversals, for example. You getting me? So we need that leadership. And I hope the incoming leaders in 26, like myself, we shall congregate around these issues. You are getting me? So that parliament is meaningful. This is the purpose why some of us with our PhDs, we want to go there. I saw there are 16 PhDs in parliament. I want to be the 17th or 18th. Okay? So that we go there and we say, look, we didn't go to school for nothing. This PhD should mean something. There should be a difference between parliament and an LC1 meeting or a district council meeting. Because we are parliament. We are the best brains. It doesn't matter whether you are from Essex or what. You just perhaps you delayed your reading or you are unfortunate. But now that you are here, can we think and represent the voice of the people? And health is uniting.
People have been speaking in that
whether
house.
you are FDC. No, but in parliament there is political action. There is talking and there is political what?
Action.
The NRM caucus must congregate, must raise the issues to the extent that what they did in 2012. Do you know the first salary increase we had in for health center for people?
They declined
1.5.
They declined to
because of the NRM caucus. So the NRM caucus must impress it upon the president that while you invest in defense, there was no single bullet which was shot during COVID except to kill some people. You remember? Someone was killed by all hearts and people to tame them, lock them down. The bullets that were needed were tablets. You are getting it?
This
so
discussion,
we must change the thinking.
This discussion is not about to end. Dr. Kabweru, your final comments in a few seconds.
First of all, I want to thank the government for whatever they are putting in, but I also implore the health workers actually to be available on their duties and also to make sure that actually what belongs to the patient should be delivered to the patients. But we shall also call upon government to make sure that some of these bans again, they should not appear but be lifted, and especially in the health should be left alone to just freelance.
With that, we come to the end of Spectrum. I must thank you very much, dear doctors, for actually making time to come here and discuss this very important topic. Thank you very much, dear listeners, for listening in and sending in your views. Well, I've been your host, Kenneth Lukwago. And as on up next, we have the news in English with Miss Josephine Dagano. Thereafter, we'll have the Soul Train with BB Jr.